Next slide, please. So welcome to today's webinar on when grief becomes complicated. This webinar is sponsored by the Northeast and Caribbean Mental Health Technology Transfer Center, or MHTTC, housed at Rutgers in the School of Health Professions in the Department of Psychiatric Rehabilitation and Counseling Professions. My name is Kathy Rivera, and I'm the project coordinator of this center and will be co-facilitating this webinar today with my colleague PJ Wenger. Next slide, please. The MHTTC is funded by SAMHSA, the Substance Abuse and Mental Health Services Administration, to enhance the capacity of the behavioral health and other related workforces to deliver evidence-based and empirically supported practices to individuals with mental illnesses. Please visit the MHTTC Network website for additional information at mhttcnetwork.org. Next slide, please. If you're interested in staying up to date with the events and products the Northeast and Caribbean MHTTC is providing, please sign up to receive our email communications. You can sign up at the bit.ly link provided on the screen. Next slide, please. Following the webinar, you'll be asked to complete a brief survey. We value this feedback and use it to improve our activities and inform future activities. The surveys are also important because our continued funding is linked to the completion of these surveys. So we thank you in advance for your feedback. Next slide, please. We also want to let you know that this webinar is being recorded and will be posted to our website along with the PowerPoint slides in the next couple of days. Slide, please. We encourage you to interact with our presenters during the webinar by using the chat feature. Please post any comments or questions you have in the chat, and I will collect your questions as we go and ask them of the presenter during the Q&A time towards the end of the presentation. During the webinar, our presenter may pose questions to you. So please use the chat feature to answer these questions. This presentation was prepared for the MHTTC network under a cooperative agreement from the Substance Abuse and Mental Health Services Administration, or SAMHSA. All material appearing in this presentation, except that taken directly from copyrighted sources, is in the public domain and may be reproduced or copied without permission from SAMHSA or the authors. Citation of the source is appreciated. The opinions expressed herein are the views of the presenters and do not reflect the official position of the Department of Health and Human Services, or SAMHSA. No official support or endorsement of DHHS, SAMHSA, for the opinions described in this presentation is intended or should be inferred. I'm going to turn it over to my colleague, PJ Wenger, who will be introducing our webinar presenter today. And again, welcome everyone.
Welcome everyone, and we are so pleased to have Dr. Kenneth Doka here with us today. Dr. Doka is a professor emeritus at the College of New Rochelle and senior consultant to the Hospice Foundation of America. Dr. Doka has extensive experience in the area of grief, is a prolific author and speaker, providing keynote addresses internationally. He participates in the annual Hospice Foundation of America teleconference and has appeared on CNN and Nightline. In addition, he has served as a consultant to the medical, nursing, funeral service, and hospice organizations, as well as businesses and educational and social service agencies. Dr. Doka was elected president of the Association for Death Education and Counseling in 1993. In 1995, he was elected to the board of directors of the International Work Group on Dying, Death, and Bereavement, and served as chair from 1997 to 1999. The Association for Death Education and Counseling presented him with an award for outstanding contributions in the field of death education in 1998 and significant contribution to the field of paleontology in 2014. In 2000, Scott and White presented him an award for outstanding contributions to paleontology and hospice. His alma mater, Concordia College, presented him with their first Distinguished Alumni Award. He is a recipient of the Caring Hands Award, as well as the Dr. Robert Fulton CDEB Founders Award. In 2006, Dr. Doka was grandfathered in as a mental health counselor under New York State's first licensure of counselors. In addition, Dr. Doka is an ordained Lutheran minister. So coming to us with a wealth of experience, I present to you Dr. Doka.
Thank you very, very much. And my son has a much more easier introduction. He says what that all means is that you have no life, actually, but that's his perspective. Today, I'd like to talk about when grief becomes complicated. And I think we have to remember two things as we even begin this. And the first is that grief is simply a reaction to loss. We often associate grief with a death, But it doesn't always have to be a death. And certainly during the current COVID pandemic, we're seeing lots of reactions of grief, totally unrelated to the deaths, even though we are seeing obviously some death-related losses. But, most of us have lost our assumptive world, the regularity of the world, the predictability of the world. And we need to recognize that. As a matter of fact, it's kind of interesting. When Freud actually wrote about 100 years ago, literally just in almost slightly over 100 years ago, Mourning and Melancholia, which was really one of the first articles in the field, what we often consider the beginning of the modern study of grief. His case study wasn't what you think. It wasn't a widow or a widower. It wasn't a bereaved parent or a child who lost a parent. It was actually a bride abandoned at the altar. And I think he was trying to tell us a lesson we until recently forgot, that grief is about loss, not just about death, but about loss. Anyway, before we talk about complicated grief, I think it's important to really spend a little bit of time talking about what we typically emerge as common grief reactions. Because unless we understand the sort of typical reactions that people have, we may have problems in legitimately diagnosing them. And what we always say is that grief is manifested in many, many ways. We often think of it as an emotional reaction, and it certainly is, but we react in all kinds of other ways as well. And we're going to look at these in a few seconds, but we react physically, we react cognitively, emotionally, spiritually, behaviorally. So for example, our reactions, our physical reactions of grief can be all kinds of things: headaches, dizziness, exhaustion, digestive difficulties, tremors, menstrual irregularities, erectile dysfunction, all kinds of aches and pains. Many times our grief can be what we call converted to physical symptoms, especially when reactions, other kinds of reactions, are denied. It's interesting, when I'm often doing this, I'll ask to see if we have any camp nurses, nursing students who worked in camps or people who went to camp as a kid. And I'll ask the question, who sees the homesick kids first? And normally it's the nurse. And the kids aren't coming in and saying, I'm homesick. They're saying, my leg hurts, I've got a stomach ache. But really what they're experiencing are grief symptoms. A number of years ago, one of my colleagues was a pioneer, Jane Nichols, in the study of perinatal loss. And what Jane researched is, now remember, Jane started her research in the 70s, and there was really no recognition, no acknowledgement of a loss due to a stillbirth or a spontaneous abortion, a miscarriage. Those weren't acknowledged at all. And if you got any counseling at all, it was a physician saying to you, you're young, you're healthy, go get pregnant again. But it's interesting that when Jane began to study her sample of people, because any emotional reaction, because these other reactions were disallowed, they often had very physical reactions. And again, if I were with you, I'd ask for a show of hands as to where you think, or comments as to where you think these losses occurred. And most people would often say in the heart, in the breast, or in the uterus, somewhere there. And those were 2 and 3. But the biggest symptom was pain in the upper arms. And that makes a lot of sense when you think that those are the muscles you use to hold and to lift a child. So you'll see all kinds of physical symptomatology. And therefore, when you're counseling someone, it's always important to assess health. And again, if people are experiencing physical symptoms, they need to be assessed by a knowledgeable physician who number one, knows that grief can be converted physically, and 2, and two, knows that people are at risk. And again, especially widows and widowers do have a higher risk of mortality. Most of the time today, we die of different kinds of chronic conditions. And many times, those chronic conditions, heart disease, cancer, have environmental influences. So, so for instance, maybe a poor diet, maybe one partner is smoking and the other partner is breathing in that second smoke. And so we call that the joint unfavorable environment, that it's not unusual for spouses to become sick at the same time. Second of all, grief is about as stressful as experience as you can have. And of course, especially when you're older and vulnerable, stress can affect you. And then of course, lifestyle changes. Maybe maybe a widow made 2 healthy meals for her spouse all the time, or 3 healthy meals, I should say. And now she's eating out of tuna cans. So again, we need to assess health. And then of course, we do have emotional reactions to grief, and they can be very varied. One of the major ones, of course, is guilt. And it's interesting, I'm old enough to remember that song, "Love is a Many Splendored Thing." But guilt is also a many splendored thing. And a number of years ago, Margaret Miles and Alice Demi did a study of guilt and actually found 6 different sources of guilt. One was death causation guilt. And again, something doesn't have to be rational to be real. So it may be a person saying, I should have made him stop smoking. I should have made her go on a diet, things of that nature. Second of all is cultural role guilt. And you can fill in the sentence. I should have been a better mother, father, sister, brother, son. Another kind of guilt is moral guilt. And moral guilt is saying something to the effect of, this is a punishment. I did something wrong. God or the universe is punishing me. And then we can often have survivor guilt, very common among siblings, and not uncommon also among older persons who experience the death of younger persons. This is, I should have been the one who died. My parents wouldn't have missed me as much as they missed my sibling, or I'm 85 years old and I have arthritis and I have a million chronic conditions, and now my 19-year-old grandson dies. And then you can have both recovery guilt and grief guilt. Recovery guilt is the feeling you're doing too well. Why aren't I crying more? And grief guilt is you're not doing well enough. Why can't I stop crying? Everyone else has. And again, with guilt, in fact, with all these emotions, I always like what Schneidman says. It's not that we experience one and then the other and then another reaction. What happens is they affect us all at once. Schneidman uses the term, we're a hive, like a beehive of affect. I'm going to amend that a little bit and say we're actually a hive of all kinds of reactions. Sometimes we might experience relief. Relief that the person's suffering is over, relief that that we don't have to do caregiving anymore, that maybe a relief that a very painful and difficult relationship has ended. And again, it might not have been difficult and painful until the spouse received dementia, or a combination of those factors, what we call dual relief. Anger is very common. As a matter of fact, the term bereaved could be best translated from its Latin, which means to have something ripped away from us. If you go back to the 70s, to be bereaved is to be ripped off, to have someone ripped away. And of course, anger is a natural response to that. Sometimes we can experience even a sense of emancipation. We feel freed. We were caregiving 7 days a week, 24 hours, and now we don't have to do that anymore. Sadness and loneliness, very common. Yearning for the person, very common. One we don't talk about a lot, but one that I always like to mention is jealousy. Sometimes we can even be jealous as part of a grief reaction. How come your spouse is still around? How come your partner is still alive and mine isn't? Or how come, how come you have children and my child died? And then we can have positive emotions too. And what I mean by positive emotions is not that I'm glad the person's dead, although sometimes that can happen, but that's much more rare. Sometimes it can simply be, I did a study, for example, of caregivers. And often after caring for somebody for a long time, many of these caregivers had almost a kind of sense of pride. Um, I never thought I could take care of him as long as I did. He never wanted to go to a nursing home, and I was able to provide him at home. I'm a lot stronger than I thought I would be. So again, we can have a variety of emotions, and again, all swirling around within us. And then grief, just typical grief, affects the ways in which we think. It affects us cognitively. Sometimes we just feel depersonalized, like we're just going through the motions of life without any affect. We may struggle with disbelief and denial. This can't be real. This can't really be happening. Sometimes we can idealize the person, in which the person who died becomes almost a saint. And that has difficulties for three reasons. When idealization becomes extreme. And in many ways, it's supported in our culture. We often say to somebody, don't think of the bad times, just think of the good times. Focus on those. But in reality, grief involves confronting your own reactions, confronting your own feelings, among other tasks. And part of that is that most relationships have some degree of ambivalence. We love somebody, but some of the things they do really annoy us. And when we idealize the person, it inhibits that process of emotional exploration. Second of all, it makes life very difficult for survivors because we always feel like we're competing with a dead, perfect ghost. And then sometimes, of course, the other thing that happens is we can idealize very, very destructive behaviors. I once dealt with a young teenager, a 14, 15-year-old boy, whose two brothers had died of substance abuse. One of them essentially nodded out in a snowbank and died of hypothermia. The other one died within 2 weeks of each other of an overdose. But to this kid, he idolized his brothers. They were the epitome of cool. And about 15 years later, actually around his 33rd birthday, he died of substance abuse. The other process, which is equally problematic, is demonization, maybe with an abusive spouse. And again, we have to recognize our ambivalence. We can become preoccupied with deceased, constantly going over things in our head. We can be confused and disoriented. We can have obsessive thinking, particularly about preventability. If only I did this, if only I did that, if only I got there sooner, if only I made him go to the doctor. We may have an inability to concentrate or to focus. And you can see how many of these manifestations of grief can be confused with learning disabilities, particularly in children. And that's one of the reasons why it's really, really critically important when you're assessing a child for learning disabilities to have a sense of that child's losses and to do really what we call a loss inventory. And then, of course, we may search for meaning, that existential question of why did this person have to die and why now, and what is the meaning of that? And then we may have extraordinary experiences. And it's important to talk about these because these kinds of experiences can, which are very, very normal in bereavement, can lead to us looking at something as highly unusual, highly problematic. when it's really not. And these are experiences these experiences come in a lot of different ways. I'll tell you the first time I experienced it. I was a young counselor. I was just in my late 20s. I was just starting my practice. And I remember a woman who came in, and this woman's 3-year-old daughter had died of sudden infant death syndrome, which is late for that to happen, but still within the range. And at the time, that was her only child. And this woman was trying to make sense of that loss. But one of the big questions she had, and one of the major ways she was struggling with, is, can I dare to have other children? Can my spouse and I really have the family we always envisioned? And a concern was that, that no one could assure that this couldn't happen again. And she was really worried that, she didn't know if she wanted to risk it, to fall so in love with a child and then have that child die. And one of the little rituals she had with her daughter is, whenever she was going out or getting ready for something important, she'd put some expensive perfume on, and the little girl would insist that she put that perfume on her. So, she'd put a little bit behind her ear, and the little girl would run out and make sure everyone smelled her and how nice she smelled, just like mommy. And that was a mother-daughter ritual. And when the daughter died, what the mother did is she essentially, she took the perfume to the funeral home and really anointed her daughter before they closed the casket, and then put the perfume in the casket and switched to another brand, because the memory of that brand, the memory of that odor was so associated with her daughter. And one day when she came to me, and she was aglow, and I said, well, what's going on? And she said, when I went into my daughter's room, I smelt the smell of my perfume all over the room. Even my husband smelt it. And, and my mind is thinking she's hallucinating, but I kind of didn't get the sense of an hallucination. She seemed, highly tied to reality about it, but I just couldn't explain it. And happily, I asked the right question. I said, but more out of shock and discomfort than, than plan. I simply said to her, what did that mean to you? And her answer was that it was my daughter's way of telling me she was okay. And soon after that, she terminated therapy, and she later had 3 other children. I occasionally would get announcements about their college graduations and things of that nature. So sometimes we can feel just a sense of the person's presence. Sometimes we can have these sense experiences, and it can involve any of these senses. Sometimes we may have symbolic experiences. Lou Legrand, who ultimately did a lot of research about it, tells a similar story to mine. And he talks about a client whose 17-year-old son died in a car crash. And she came in one day to him, who was a therapist, and said, whenever I go to your office, I pass the cemetery, and I always stop and see my son's gravestone. He said, when I got there today, there was a hawk perched on the gravestone. And Lou said to her, that's significant. And she said, yeah, my son's nickname was Hawk. So to her, again, it was a kind of experience of the person's presence. Other times there may be third-party experiences where somebody says something that sounds that seems like a message from the deceased, or reaffirms a belief. In my son's case, he was very close to my mother, his grandmother, and she desperately missed her husband for the 10 years that she outlived him. And when she died, my son said, well, at least she was with grandpa. And one day, a neighbor across the street, he was living in an apartment in her house at the time, as he was just beginning to work in New York City. A neighbor called him over and said, my wife had the most wonderful experience. He said, she was, she saw your parents, she had a dream where she saw your parents walk up the street hand in hand. And that was very reassuring to him. And sometimes we can have very commonly our own dreams. And these can be very basic, what we call basic grief dreams. They're filled with, with different kinds of symbolism. One of my clients, for example, came in one day and she talked about her mother had died very suddenly. And she had these repetitive dreams where she was on a plane with her mother. They occasionally flew together different places. And the mother went up to use the restroom. And she seemed to be taking a long time in the restroom. And then, when the message came on to get back into your seats, the person called the flight attendant and said, my mother's not here. Would you check on her? And the flight attendant came back and said, honey, nobody's in any of the restrooms. And it was interesting. One of the ways you sometimes can counsel people who have dreams is to ask them to title the dream. And the way she titled it really made her understand it. She titled it Vanished into Thin Air. And she realized that was her experience of a mother's death. Her mother had vanished into thin air. She was there one day and died suddenly the next. And the other kind of grief can be a visitation dream. They're much more vivid. They're easily remembered. The interpretation is clear. It may be your dad saying, coming in a dream and saying, remember, the will and some of the bonds are in that gray box in the closet. And again, they're relatively common experiences. About 60% of bereaved people have them. And again, depending on your culture, it's higher in some cultures than in others. So the point is, these are not necessarily problematic experiences unless they're kind of negative in tone. These are all part of the common experience of typical grief. So again, what I ought to say this, that bereaved people have a kind of ambivalent reaction to these. They're often they find them comforting in most cases, but they also don't want to talk about it because people will think they're crazy. So I always try to solicit these and validate these. I'll often say to somebody, people have talked to me about smelling the person or seeing the person or dreaming of the person. Have you had any of those reactions? And then people say, never told anybody, but allow the client to interpret what it means. And of course, if they do have negative experiences, help them reframe those experiences if possible, or develop some interventions. Again, we may have spiritual manifestations of grief. We struggle with our faith. We search for meaning. We have changes in our spiritual behavior. Some people find themselves closer to God or whatever they believe in. Some people find that their beliefs are deeply challenged. And then we have behavioral manifestations of grief. We lose patterns of conduct, we cry, we withdraw, we go through interpersonal changes. Some people avoid reminders, some people seek reminders, some people some will withdraw, and other people just constantly having to be active. And sometimes people have sexual dysfunction as well. And I always describe the normal grief process as a kind of roller coaster. You have good days, you have bad days. And if you ever ride a roller coaster, ridden a roller coaster, usually in the very beginning, it's not as bad. You're going up the hill kind of slowly and you're thinking, I can handle this. And then you hit that first downturn. And usually about 4 to 6 weeks later, and people are saying, I'm getting worse rather than getting better. But that's very natural too, because in the very beginning of the loss, you may be in a state of shock. One of my colleagues, Terry Rando, says, most people die suddenly. And then she adds, in the midst of chronic illness. So even though somebody may be very sick, we don't always expect them to die the day they did. Maybe we think they have a few more weeks or something like that. So again, you're busy and you're involved, writing, arranging rituals, writing thank you notes, doing whatever you need to do. And it's usually after that that you begin to experience those ups and downs, and they can last for quite a while. Um, by the way, if I were using this with a client, be very careful about metaphors. So the first thing I would say to you is, have you ever ridden a roller coaster? And if you said, yeah, I used to ride them all the time when I was younger, I still like to go on them. I'd say, well, you're kind of on a different kind of roller coaster now. You're kind of on a roller coaster of grief. But if somebody said to them, I'm terrified, I never rode a roller coaster, you don't want to turn to them and say, well, you're sort of riding one now, because that just adds to the terror. We also recognize that grief is a time-bound process. It's not a time-bound process. There's no 1 year and you're over it, 6 months and you're over it, and it doesn't end up in detaching. We stay connected to the person. We always retain a continuing bond with that person. And often that's one of the first things I do when I'm doing grief therapy. I'll say, what are your goals? What are you seeking? And people will give you the response they think they're supposed to give you. I guess I should move on. I guess I should forget the person. I guess I should bring closure to this. And what I always stress is that, that I'll often say to people at that point in time, is that what you want to do? And they'll say, I never want to forget this person. He or she was the love of my life. They were my parents. They were my kid. And I'll say, the first sign that you're doing better is when you're able to laugh at a story and remember a story that's now too painful to recall. You really want to emphasize that you will never lose that bond. It'll change now. It'll become not so much a physical and interactional bond, but an emotional and spiritual bond, but it'll never go away. So what I like to talk about is what I call grief amelioration, that over time, for most people, pain diminishes. The roller coaster begins to even out. You have more good days than bad days, and finally, mostly good days. Individuals function as well as they did, sometimes even better. One of the things we're not talking about today is what we call post-traumatic growth, that some people will actually improve as a result of their loss. But that grief has a developmental aspect. That means even years later, we can have those surges of grief. It may be the young woman who's 15 years old when her father dies, and 12 years later, as she's undergoing loss. 12 years later, maybe when she's going on a wedding, and her wedding, and she looks at her side and she sees her brother there, or a stepfather there, or a grandfather, or a mother, or somebody else. She says, my dad should be there, and there's a surge of grief. And all of that is very, very normal. As a matter of fact, when I'm terminating with clients, I'll say, there are going to be moments, painful moments in the future, when you wish your dad was, or your mom, whoever you lost, was there. What might some of those moments be? And and help them to recognize when they come. That's not unusual. We always stay connected. People are part of our memories. They're part of our biography. If you knew my family, you'd see part of my father in me. You'd see part of my mother in me. They give us our legacies and liabilities. I always start each day by making a list of things to do. My father did that. My son does it. So we have those legacies and liabilities. We have our spiritual beliefs that may look toward different connections. Whatever those spiritual beliefs are. And as I said, we've often had those extraordinary experiences. We also have to realize that not all continuing bonds are good. Some are problematic. I call those when the ghost rules. I made a promise to my husband when he was dying, or my wife when she was dying, that I'd never marry again. And 5 years later, the client has met somebody and they're sort of, they want to move on to their relationship, but they really feel they can't. Or other times the connections are problematic because there's no acknowledgement of loss. And all of these impair growth. And again, the research says, that some continuing bonds can be associated with complicated grief, but obviously not are. Now, everything we've set up until now is what's considered typical grief. But now we're moving into what I call more complicated forms of grief. And the first set I'm going to talk about just for a moment, just for a single slide, is what I call the warning signs, the yellow lights, the caution signs for a therapist. One is they begin to take on the behaviors of the deceased. And as I said, that's a warning sign because it may be that they're just having to adjust to the loss. So the father was the disciplinarian and now the mom has to be much more of a disciplinarian. But sometimes it means they really can't let go of that person in any way. And they want to sort of bring that person back in their life by acting like them. Or they begin to experience symptoms of the deceased illness, which again, sometimes can in fact be that they a mutual diagnosis. And sometimes it can be again a sign that that their bond is not evolving. Now, here's where we get to the stop signs. Here's to where we get to what might be more complicated grief reactions. And these are self-destructive behaviors, obviously, including substance abuse. These are behaviors destructive to others, or one of the words that I like to use, even more than I like to use the word complicated grief, is disabling grief. That grief over time, they're still not able to function in their key roles. And again, it could be because the grief triggered a depression, but that grief is really, really disabling them. And so this brings us, now that we've contrasted it with typical grief, this brings us to more complicated grief. And estimates show that anywhere from a fifth to a third of people have risk factors which we're going to look at, that may complicate that loss. And anywhere between 10 to 20% of people actually exhibit some form of complicated grief. Just to give you some definitions of complicated grief, the Rando defines it as a generic term indicating that given the amount of time since the death, I would say since the loss, there is some kind of compromise or distortion or failure of the mourning process. Strobe and their research group say it's a significant deviation from the cultural norm, either in the time or intensity of grief, or in the level of impairment. So again, they're stressing too that grief is disabling. And Catherine Shear, who's done a lot of work on complicated grief, looks at it this way. People start out with acute grief. Sometimes that becomes complicated. And other times it just becomes the loss becomes integrated with their life. But again, sometimes that can be wrought with change, and grief again becomes complicated. So what are some of the symptoms that might show somebody is having a more intense reaction than the symptoms we mentioned? And that's where even over time, they cannot speak of the loss without intense grief. I remember once seeing a client, this is about, and I thought the intensity was just so extreme. And then when I looked at the file, I realized her loss had been, and when I asked her the question, I realized her loss had been 7 years ago. But even 7 years later, it was incredibly intense. Sometimes a minor event triggers grief, that when they talk, they're always talking about loss. They develop symptoms or behaviors of the deceased. They refuse to change the environment. And again, a mental health history. They have a history of depression. They're self-destructive or other destructive, and grief is disabling. Any of these signs are like red flags. They say something may be happening here. And again, other research has found factors that may lead to complicated grief. So for example, Bonanno and his group's research indicated that when people are excessively dependent on the person, that's one of the best factors or best predictors of a more complicated grief reaction. You're highly dependent on this person. Scott and White, Gamino and his associates out of the Scott and White Hospital did a study, and they found 3 major factors and then 2 other ones that were significant. That's why I have it in that way, that led to complicated grief. Was obviously the younger the age of the person who died, the more complicated the grief was going to be. We, especially in Western society, expect people that they're born, they go through the process of senescence, and aging, and then later on in life they die. But when somebody dies at 35, that's not usual in our experience, and that's problematic. And in association with that death, most of those deaths are in fact from traumatic reasons. Don't have to be, but often that becomes another factor. And of course, a big factor is the perception of preventability. If somebody gets, for example, prostate cancer or liver cancer, you say, I'm not sure if anybody could have prevented it. But if it's an accident, if it's a heart attack, that really gets going what I call the if onlys. If only I had did this, if only I had done that. And then, of course, you might have a history of mental health treatment. And again, it's important to look if the person has had prior anxiety, prior depression, because grief is likely to trigger those as well. And then again, just the number of other losses that they've experienced. It's one thing to lose a parent, and then 5 years later lose another parent. But it's different when you have lots of losses cascading on you. And so that's problematic. Again, other research has said the person's not functioning in 4 months. That's predictive that the person's going to be, grief is going to be more complicated. So we also have to recognize that we can have disenfranchised grief. And this refers to some of my work that says losses that can't be socially sanctioned, openly acknowledged, or publicly mourned are more likely to lead to complicated grief. And Rando has identified disenfranchised grief as a factor contributing to complicated grief. So for example, it's one thing to lose your spouse, but it may be problematic to lose your ex-spouse. You still have, there's still a bond there of one form or another. And there are other factors there then too. So again, or suppose you have a illicit lover in an extramarital affair. That's going to be a complicated loss. So we've got to realize that disenfranchised grief runs there. So just to kind of sum this up, what have we found associated with complicated grief? Prior losses, exposure to trauma, psychiatric history, attachment style. Some people have very secure attachments. Others, the attachments are much more ambivalent and therefore more likely to be problematic. Prior relationships. And then there are factors associated with the loss itself. Was it violent? Did it involve a long caregiving history? And how was that experience for people? If it was very difficult, people may be very ambivalent about the death. There's part of them that says, I just wish this would be over. And then they may feel intensely guilty about that. Was it a highly dependent relationship? Was there any opportunity to prepare for the loss? What kind of social support are they getting? Or is in fact the loss disenfranchised? So those are the factors that lead to disenfranchised grief. And then the question becomes, how can we classify forms of complicated mourning? And William Worden, whose book, by the way, if you're going to buy one book in the field, I would certainly recommend Bill Warden's Grief Counseling and Grief Therapy as one of the prime candidates. But Bill Worden talks about what he calls 4 different syndromes of complicated grief. And one of these syndromes is what we call chronic grief. And what we mean by that is that in chronic grief, the roller coaster never ends. It's always always there. So we're always sort of struggling with that sense of complication. We don't have that roller coaster just at a high level all the way out. Another kind of grief is what's called exaggerated grief. And exaggerated grief to Worden means that certain manifestations of grief seem to predominate, seem to be highly exaggerated. So it's normal that we might feel angry, but here we're raging. Or it's normal that people experience guilt, but here the guilt is obsessive and compulsive and almost total. They may be engaging in ritualistic behaviors like the constant hand washing or something like that. So whatever the manifestation of grief is, it is highly, highly exaggerated. And then we may have what we call mass grief. And I know many of you in this audience are involved with substance abuse issues. And those are the kinds of things that happen there. So the problem that presents itself is the problem of delinquency. But underlying that delinquency is loss. I just can't think of the name of this study, but years and years ago, it was a husband and wife team, famous for you always read about them in introductory psych, and I just can't think of their name right now. It's right on the tip of my tongue, and I'll probably think of it before the end of this presentation. But they were the ones who defined the term mesomorph and ectomorph and endomorph, and they were interested in body types in delinquency. And they collected huge amounts of data, and they followed these kids, sometimes from 6 years old to 16, literally did 10 years longitudinal studies to see which of these kids would turn out to be delinquent. And their whole theory was that it was, that certain body types would engage in certain kinds of behaviors. And as I said, the results now become almost laughable, but it would be stuff like, the well-built mesomorph is more likely to be a mugger than the ectomorph or the endomorph, than the skinny kid or the heavy kid. The skinny kid's likely to become a cat burglar. When we look at that and we say, yeah, well, that's not, where's the level of causation here? Or is it just simply a level of opportunity? But they had all this wonderful data that they really, as I said, were transfixed by body types. This was in the 1920s. And later people examined that. One of them was Draper, a researcher by the name of Draper. And they saw 2 types of delinquency. One was what they call just emerging delinquency. This is the kid who's stealing milk money in kindergarten and robbing stores by the time he gets to be 16. But the other type, what they couldn't really understand, was episodic delinquency. This is where a person seems to be growing up, there's little delinquent behavior, and then all of a sudden, there's a series of delinquent episodes, and then it abates in most cases. And what they realized then, and when Draper began to reanalyze that data, what he found was that the most predictive element of this episodic delinquency was the fact that the kids had a significant loss in their home within 6 months of that. So they're acting out, and Draper then confirmed that with his own contemporary research, was often a way of masking their grief. You often find that in substance abuse, so it presents itself as substance abuse, but underlying that is a sense of grief. And then the other type of grief, which many of us may actually experience, is what we call delayed grief, as another form of complicated grief. And this means that you don't experience grief at first, and then maybe years later, something triggers that grief. And the reason I say we often experience it, because probably many of us are what I call the do something child in the family system. Somebody's problematic and we're supposed to do something about it. So we become the caretakers and the caregivers, and we put aside our own grief to help others. I remember once counseling a clergyman who came to me, and he was very upset. Within the last 6 months, he had buried his mother, an uncle who was a very favorite uncle of his brother, slightly older brother, and then a dog. And he said, the only death I cried at was the dog. And as he talked about it, my comment to him was the problem with the dog was the dog didn't have any puppies. And he looked at me like I was crazy. And then I said, look at what you did. In every other loss, you dealt with it by taking care of other people. You took care of your nephews. You were there for your brothers and sisters when mom died. You were there for your uncle's family, your uncle's widow when she died. As a clergyman, that was, you perceived that to be your role. This was the first loss that was yours. And he wasn't just crying for the dog. He was crying for all the losses he had experienced. And as caregivers, we have to be very careful to make room for our own grief, lest it become complicated. So again, we've looked at this already, the symptoms of complicated mourning. And again, the danger with complicated mourning is that complicated grief is often related to what we call often related to both physical and mental health morbidity. In other words, people are more likely to get sick, people are more likely to get mentally sick, or even to find illness. We need to treat it. And of course, studies have shown that there actually is a treatment that's developed by Catherine Shear and her association called complicated grief treatment. And you can be trained at this at Columbia, at her center, as well as other places. But it's a method that emphasizes psychoeducation about grief. It talks about retelling and meaning-making strategies, particularly with traumatic loss, and what's called a dual process approach. And the dual process model is a model developed by Strobe and Schutt from the Netherlands. And what they say is that there are two processes in grief, simultaneous processes in grief. One is where you have to really kind of cope with the loss, and the other is you have to restore or rebuild life now after the loss. So you're kind of between two processes. And what Strobe and Schutt say is that you need to oscillate between these two processes. So you both have to process the reality of the loss and at the same time build a life now that incorporates the loss. I'll give you an example of that. I had a widow once come in to me, very, very happy. Said, for the first time since my husband died, I balanced the checkbook. But then the next week she said, after I left her office, I kept thinking, but if my husband were alive, I would have never have to done that. So you see this kind of oscillation, this constant moving back and forth between mourning the loss on one hand, and on the other hand, rebuilding life in the face of the loss. And what Shear's method does is it says, we've got to work on both of these things in that oscillated way. And the research has shown it's more effective than interpersonal psychotherapy or present best treatment. So again, just to give you some examples, don't do this at home unless you take the training. But for instance, we have to we have various strategies we have to use. We have to address complicating thoughts, behaviors, feelings. We have to then oscillate between confrontation and comfort. We have to attend to the dual process, dealing with the loss and the future. And again, so it involves psychoeducation, retelling the story of the loss till it becomes part of us, involving sometimes significant others who need to be part of our process, monitoring our grief, revisiting exercises maybe where we have to kind of look at our behaviors again and really check out our guilt. I'll give you an example of that. A number of years ago, I was dealing with a man whose wife died of lung cancer, and he kept saying, I should have made her stop smoking. I should have made her stop. He couldn't get past that he should have stopped her smoking. He didn't smoke. He knew it was dangerous, but he couldn't stop her smoking. And one of the things that we did here is I asked him to tell me then, to imagine, to close his eyes and imagine how he could make her stop smoking. And it was really interesting process to watch, because he sat there with his eyes closed and he'd do this. And finally he said, I thought about all the ways I tried to stop smoking. None of them worked. He said, I did all kinds of things. I talked with her, I pleaded with her. There were times I even cried with her when she'd have a bad cough and a bad coughing spell. He said, I'd hide her cigarettes, I'd break her cigarettes. He said, one time my grandson came over with one of those blaster, water devices where he said, whenever I saw her smoke a cigarette, I'd give her a blast with the water pistol. He said nothing stopped her. And then he realized I couldn't have stopped her. And that was very important for her. Reviewing memories and pictures. These can be important techniques to help people deal with more complicated grief reactions. For example, one woman was a caregiver for a husband for many, many years with Alzheimer's. And one of the issues that she had was, I cannot remember. All the memories of him before the disease have been blocked out by the horrible events of the disease. And as he did that, as she began to think about that, I gave her an assignment, and I said, I want you to take a photo album, a new photo album, and do like a history of your life together. And when she did that, that helped restore some of the older memories. Sometimes you can have imaginal conversations with the person who died. I once had a young boy who was 11 years old when his dad died, and he had a great relationship with his father, but when his father developed cancer, it really scared him, and he felt very, very guilty. Really was consumed by guilt, because the last session with his father, he wasn't aware that his father was so close to death. Nobody was. Again, we die suddenly in the midst of chronic illness. And what happened is that as he was that he wanted to get home. He didn't like being around the hospital. It scared him. It scared him to see his father, who was almost skeletal at this point in time. And the father, and so he was trying to push his mother out. I think he even had a basketball game that day. Uh, and the father said, give me a hug. And he said, not tonight, Dad. Tomorrow we got to go. And of course, his father died that night, and he felt overwhelmingly guilty. And so I did an exercise with him, similar to the empty chair exercise, where he spoke to he told his father. I said, imagine your father sitting in that chair, and I want you to have a conversation with your father about what happened that day. And he started crying and said, I'm really sorry, Dad, and all this kind of stuff, and really poured out his heart. And then I said, now I want you to sit in that chair. And I want you to I want you to answer as you think your father would. We sometimes describe this as accessing the other. And he sat in the chair, and it was the most remarkable experience. He was about 14 at the time. And he looked, and he kind of laughed, and he says, "Is that what's bothering you, Bud?" And he started laughing, and he said, "That's exactly what my dad would have said." And to him, it was a really growth. And of course, we need to let our clients pay attention to their self-care, their core values, and look at a future. So again, there are treatments for complicated grief. This is just a model of the treatment that SHEER uses. The introductory phase. Again, you can see psychoeducation. You can see, beginning to lay the groundwork for all of this in the first 3 sessions. The middle phase, you really see that, which is the heart of treatment to SHEER. You really see that dual process. Again, dealing with loss and dealing with restoration. And then the terminal phase is the transitional phase. Again, summarize gains and plans for the future, process termination. And part of what I would add to that, and I'm sure SHEER does it, is to talk about when you're going to have those surges of grief that are very, very normal and natural as you go through your life, to just give persons warning that goes. Well, let's deal with one other issue, and how to classify complicated grief, and how do we classify complicated forms. And this is a really interesting and current debate, because in recent years, of course, we developed the DSM-5, and the DSM-5 really did make some significant changes, some of them very controversial, in how we look at grief. And of course, I don't have to, when I'm doing this to my students, most of them are starting out, and they really need to know about the DSM. And again, if you look at the history of that, the DSM-3 introduced the term bereavement exclusion for major depressive disorders. And what they were afraid of was that people who were grieving would become overdiagnosed and overmedicated. And so, for instance, so you couldn't diagnose somebody with depression, depending on which volume of the DSM and which version you looked at, for a period of time if someone had a recent bereavement, 6 months, a year, whatever that was at the particular version. And up until the DSM-5, there was really no way to categorize complicated grief reaction outside of other conditions. And that's beginning to change now. And again, as the DSM was being prepared, there was considerable discussion over if and how complicated forms of grief should be included, including whether it should be included at all, because there was big debates about that. Some people, like Phyllis Silverman, who did some of the initial studies of widowhood, said, hey, loss is a normal transitional event. People can be complicated. They can have a variety of mental illnesses and things like that. But grief isn't necessarily complicated. And others, kind of upped that a little bit and said, well, we really should use what we have. Certainly, loss can be a precipitating factor in depression, anxiety, and separation disorders. Others thought, yes, but not the way you're doing in the DSM-5. And I'm going to talk about the persistent persistent complex bereavement disorder in a minute as something that was a candidate disorder. And then other people said, yeah, but right now you're putting all your eggs into one basket. And as Gordon said, there are lots of ways that we grieve. And then other people said, yeah, let's just do it because early identification offers therapeutic benefit to the client. So, ultimately it was included, and there were certain advantages of that. And one was the acknowledgement that grief can be complicated and may need treatment. And obviously, if it's in the DSM, one of the factors is that treatment now, if you can give a number to it for many insurance agencies, can be reimbursed. The disadvantage and the fear of putting a treatment for complicated grief is that there was the risk of overdiagnosis, that that everybody would have complicated grief now because that was a way to justify counseling, or the risk of over medication, that you could that people who were just having normal grief reactions would be given pills. And you could almost envision the commercials. You're walking on the beach with your spouse or your partner, and all of a sudden that person fades out, and then you can get the little green pill that says grief away. Talk to your physician about it. And this came in very, very clearly as we began to talk about bereavement. And one of the things that they did was they removed the bereavement exclusion. You can now be diagnosed for a major depressive disorder and later on adjustment disorders. And the argument for elimination was that many events and stresses can trigger depression. You can lose a job and somebody could be depressed. And yet, if you lose a person, you couldn't. That seems strange to me. But there was that argument. As a matter of fact, my own professional association took a stance against it, but I was one of the few people who disagreed with that. To me, if it quacks like a duck and looks like a duck and walks like a duck, it's probably a duck. And I couldn't see how you could, as I said, lose a job, crash a car, and be depressed. But on the other hand, you can lose a child or a spouse and not be depressed. And of course, there was the argument, as you're going to see, that it would create overdiagnosis and over-medicalization. Hasn't seemed to happen. And one of the things that I think the DSM really does well, DSM-5 really does well, is it reminds the clinicians of the differences between depression and grief. And that's been a longstanding issue. Freud's first article, Mourning and Melancholia, was trying to do the exact same thing. How do we differentiate depression from grief? Again, the arguments against elimination was that it might overdiagnose, and that mild, depression can be a common manifestation of grief. The other thing the DSM did really, really well is it acknowledged other forms of complicated grief. So for instance, separation anxiety disorder. And while the DSM-5 makes the distinction, while that grief involves yearning for the deceased, fear of separation from other attachment figures is the central factor in separation anxiety disorder. So, so what's happening is, let's say one of your children die of something, and then all of a sudden you don't want to be separated from any of your children. When they go to school, you're deeply anxious that something's going to happen. And now, of course, that can even be diagnosed in adults. So it does allow us the diagnosis of separation anxiety. It also has that as a category in adjustment disorder. And adjustment disorders are problematic responses to life stresses. So again, you can have an adjustment disorder due to a job loss, due to a loss of a person, And again, that opens it up. So again, just to kind of review this, and we'll move towards summation in a minute. What really is important here is that, well, just to note the changes in the DSM-5, we use Arabic rather than Roman numerals, and this will lead to minor revisions coming out as 5.1, 5.2. Uncomplicated bereavement retains that V code, and we'll talk about that in a minute. But we do have complicated grief as a subtype of adjustment disorder. You now have I'm just trying to set myself up for the next piece on this. When the DSM was being developed, there were two groups of people proposing two research groups proposing slightly different diagnostic categories with overlapping criteria. So one was Holly Prigerson and her group, which was advocating for what they called prolonged grief disorder. And then the other one was Catherine Shearer and her group, arguing for what they called complicated grief. What happened is the DSM-5, and remember, this is always by consensus, decided to develop a kind of candidate. They have candidate disorder. So wasn't a full disorder, but they suggested a condition called persistent complex bereavement related disorder for further study to be included as a form. And what happened in this is that, it tried to sort of do a shotgun marriage between these two forms, and nobody was happy with it. So we'll talk about the result of that. And then, of course, the last thing the DSM-5 did is it removed the bereavement exclusion for major depressive disorders. So again, now you have a list of the complications of grief: adjustment disorder, separation anxiety disorder, major depressive disorder, persistent complex bereavement disorder, which now is likely to become prolonged grief disorder. So again, in the text revision that's going to happen, there's been enough research to establish prolonged grief disorder as a legitimate category. And that's likely, from what I read and from what I hear, what's likely to occur is that in the next edition, the first revision, the DSM-5 TR, it's likely to be prolonged grief disorder is going to be one of the, not a candidate disorder, but the other ones will be dropped. Also, one of the complications of grief can be, of course, post-traumatic stress disorder. And of course, it can be an increase in physical mortality, including suicide, and an increase in physical and mental morbidity. So we see a lot of different ways that it's complicated. And again, here's what we say about that. Just to give you additional concerns, I was part of an article with Colin Murray Parks a number of years ago that called for a recognition of that there's not one category of complicated grief, but there are many, many categories of complicated grief. And of course, some of those are what what we've talked about and what we're looking at, maybe, a chronic form that sounds like prolonged grief disorder, but masked and delayed grief and all these other concerns probably will end up, I hope will end up in future, once the research is in, on future editions of the DSM. And of course, remember that, that of course, the DSM includes V codes, which are assorted conditions that may or may not be mental disorders, but are a focus of clinical attention. And again, to sort of sum this up, and I want to give at least 15 minutes for questions and answers, however we use or categorize this, we have to understand that complications can arise in the grieving process. And let's face it, grief is complicated, people are complicated, relationships are complicated, so they're also complicated. So never lose the sight of the individual in the diagnosis. Always say, how is this person dealing with their grief? How are they dealing with their loss? And how can we help? And now we get to a point where we can have some questions and answers. Thank you so much for your patience.
Thank you, Dr. Doka. That was wonderful. And we do have some questions in the chat box. So the first question is, what are the differences and similarities between complicated and prolonged grief?
Oh, there are, and I'm taking this question. Let me make sure I'm answering this question correctly, because I'm going to answer it in two ways, actually. The first is, I think what this question is really referring to is that, when proposals were made to the DSM-5, appropriate committees of the DSM-5, there are two proposals on grief. One was, as I said, Shear's proposal with complicated grief. One was Prigerson's group with prolonged grief disorder. As I said, the committee attempted to reach a compromise by melding those two forms into what they called persistent bereavement related complex, related complex disorder. That pleased nobody. Essentially, the differences were, and I don't have those differences in front of me right now. So they involve the timing involved in at what point in time you can make that diagnosis. It involves slightly different attention on different kinds of manifestations or different kinds of symptoms of complicated grief, and the like. I've never, one of my objections, and one of the objections that, as I said, we made in our paper, which is a call to action prior to that, was that one of the things we didn't like was to kind of almost the kind of, for lack of a better word, imperialistic title of complicated grief. And what I mean by that is that one of the things that I believe and hold to is that there are a variety of forms of complicated grief. And to simply say, this is complicated grief and this is other things is problematic. I would prefer recognizing that there are lots of syndromes that can complicate grief. And to use one term is, to me, problematic. So I hope that helps.
Okay, Dr. Doka, I'm just going to ask you to advance the slide to the next slide for the QR code while we answer the rest of the questions so that people can do the evaluation. Question 2, what does time mean? How long is normal to still experience acute grief?
Whoa. The questions aren't easy today. But the answer would be really, I guess what I'm trying to say and what I want to say is that time is one of the less significant factors. When I'm assessing it, I want to see that roller coaster. I want to see that roller coaster easing over time. I would expect that it's going to be, that people are going to say, yeah, first 6 months to a year were very rough. Second year was no picnic, but again, the roller coaster sort of went down. To me, the three significant questions other than time were really four. Is, first of all, are the reactions as intense as they used to be? And if person says no, over time it's gotten a little bit easier. The second question would be, so do these bad reactions come as often? So you're going to still have your downs, your ups and your downs, but are the downs less often? Are they less intense? And of course, the most important question is, in the beginning, grief is very disabling for most people in acute grief, but are you finding you're able to function much, much better now? So again, 5 years later, 10 years later, my grandson was born about 10 years after my dad died. And I remember as soon as my son called me with the message that I had my first grandson, I remember trying to call my dad and then recognizing, wait a minute, he's been dead, and feeling in the joy of that moment, the sadness that I couldn't share this with my father. And there were some special reasons why, in terms of naming and things of that nature. But but um, but my point is that time is less significant to me. I'd be more concerned with process than I would be to put a timetable. I really don't want to put a timetable on grief, but I'm saying that over time, most people would say it's less disabling, it's less intense, it doesn't last as long, the bad feelings don't come as often. That to me would be a more typical process of grief, a less complicated process of grief. Reluctant to put timetables on it.
Thank you, Dr. Doka. Next question. Are there some cultures you have studied that deal with grief better than others? I am reminded of some groups wear black for a set period of time.
We're what?
Wear black for a set period of time.
Yeah, I mean, that was, there were in some cultures, there are widows are always expected to wear black for the rest of their lives. Doesn't matter if they're widowed at 35. I like to look at it this way. I don't like to say one culture does it better and we all should learn from them. Cultures differ in their ability, in the ways people attach, in the relationships that matter, in the way that in the styles and ways that we grieve. When I approach culture, I always approach it with this question. How is this person's cultural background, their own cultural beliefs? How are they facilitating the grieving process, and how are they complicating the grieving process? I don't want to talk about cultures that are better or worse, but I want to acknowledge the varied strengths you have in different kinds of cultures. So for instance, in many tribal cultures, grief is far more communal. But they may have other issues and other problems as well. I work with the Inupiaq people of Northern Alaska. They had a lot of things that facilitated their grieving process. Rituals tended to be very community oriented. You had to bury people at certain times of the year because you're dealing with the frozen tundra. And they became community events where the men would dig and the adolescents would bring hot water to soften the ground, and the women would make food and feed people during the day, and the community would come together at night and feast and dance, and those were very positive. But they also had other kinds of things which were weak, which were problematic. Many deaths were disappearances. If I make a wrong turn in Poughkeepsie, New York, I may be 10 minutes late. If I make a wrong turn in the tundra, consequences can be far more severe. So, again, among the Inupiaq, alcohol and substance abuse tend to be complicating factors. Remember, as with many indigenous people, especially in the Americas, liquor, European, old world people whose roots are in the old world, Africa, Asia, Europe have been dealing with fermented drinks for 30,000 years. Literally, we found substances of a beer-like substance in that dates back about 30,000 years. People in the New World, indigenous people in the New World were only exposed to that 400 years ago. So substance abuse can be a complicating factor. So my question is not to say which culture is better, but what are the strengths and limitations of each culture? How do they constrain and how do they complicate and how they facilitate the grieving process?
Thank you, Dr. Doka. Next question. What about complicated grief of a person who was abused by a parent and there was no reconciliation between the two?
One of the big factors that certainly affects grief is ambivalence. The more highly ambivalent a relationship is, the more difficult it is to grieve that relationship. And of course, that relationship where and abusive relationships tend to be highly ambivalent. You find the cycle, for instance, in spousal. where there's an incident of abuse, and then the person is wants to make up. They're as nice as going to happen. It's never going to happen again. And then of course it does. So you're looking here in abusive relationships with highly ambivalent relationships, and just like with idealization, you have to ask the question, what did you like about the person and what didn't you? Here you have to ask the question, what didn't you like about the person? What, how did but were there good moments, to get the person to recognize and recognize the abuse. And again, abusers often, and their abusees, whatever kind of abuse you're talking about, often do have these highly ambivalent relationships, which are right next to dependent relationships, extremely complicating in the grieving process. Complicated relationships means complicated grief.
And last question, how do we help normalize the conversation on grief? Grief is sometimes an uncomfortable subject. So how do we support a person in their grief and allow them to express themselves without judgment?
Well, of course, that's the heart of therapy, that we provide a non-judgmental experience. I think the important thing to do is to allow the person freedom, and again, recognize that dual process. Sometimes the person doesn't want to focus on their loss. Sometimes they need to, so people are going to oscillate between the two. I think a second factor that really is important is don't judge how they grieve. Some of the work that Terry Martin and I have done have been on what we call grieving styles. And we identify two different styles along a continuum and some people, when they experience grief, they experience it as a highly emotional reaction. They'll describe their grief as waves of feeling just flowing all over them. I felt this, I felt that. They'll when you say, how did your grief express? They'll cry. They say, I cried, I shouted, I screamed. And what helps, they'll say, I needed to process my feelings. I needed to talk to a therapist. I needed to talk to a grief group. I needed to talk to my clergy or my best friend, my confidant. On the other end of the continuum are people who grieve in more cognitive and behavioral ways. When you say to them, how did you experience grief? They'll say, I just kept thinking about the person, or I felt like somebody had punched me in the gut. And it often, and when you say, how did it come out? They say, I just talked about the person. I told stories about the person. And when you say what helped, it's often the doing and the speaking. When Terry Martin and I did our study, we interviewed a person whose daughter had died in a car crash, 16-year-old girl in Maryland, coming home one day, snowy on the ground, new driver, inexperienced, not wearing a seatbelt. And as she turned the corner to her house, probably going a little bit too fast because she knew she was late, the car overturned and she was immediately killed as the car rolled over and crashed into a neighbor's fence. Literally the day his daughter was buried, he was out there fixing the fence. And the neighbor came out running saying, John, you don't have to do this. Don't worry about it. We'll take care of it. And he said, no, I need to do this. And he told us later on, it was the most therapeutic thing I ever did about, I couldn't fix my daughter. I couldn't fix the car, but I could fix the fence. I needed to fix that fence. So again, recognize we all grieve individually. Don't impose your grieving style on somebody else. Let them talk about grief as they express it and talk about it.
So thank you, Dr. Doka. That concludes our questions that were in the Q&A. I just wanted to let you know that we have wonderful feedback in the chat box about how appreciated the presentation was, and everybody is looking forward to the next webinars.
I was just going to do a commercial for the next webinar. See you next week.
Go ahead.
I look forward to talking about moral injury with you next week. So please join us again.
Okay, thank you very much. And thank you everyone for attending. And we look forward to seeing you back with us next week.
Till then.